Hey guys, I hope I'm live and audible to all of you. Just give me a thumbs up if you're able to hear me loud and clear. Okay, so those who don't know me, I am Dr. Patel and I teach medicine for PW Med, and we are running this series called as Read Harrison's with Dr. Santosh. And in this series, we will take up some crucial important topics from Harrison and we will try to dissect it down to simple basic points so that starting from second MBBS, you can start understanding the core of medicine. Okay, so this session is about the approach to bleeding disorders. Now, when I say bleeding disorders, what does that mean? That means patients presenting with tendency to bleed with trivial trauma. See, normally we bleed when there is a major trauma. We're unlikely to bleed by trivial trauma, but when with trivial trauma or without trauma, patients start bleeding, right? Then there is a problem with the patient, and that's why we will be saying that they have tendency to bleed. The tendency to bleed can either be because of defects in platelets or coagulation cascade. So based on that, we further divide them into platelet disorders and the coagulation cascade disorders. We will go there in a bit. But to understand the concepts better, we need to understand the physiology. So that's why we'll start with the physiology of hemostasis. Okay, now where do we find blood? Yes, we find blood inside the blood vessels. That means your major arteries, arterioles and capillaries, and the venules and veins. So when trauma happens to these structures, from there the blood loss will start happening, right? Okay, so now for us to understand how body stops the loss of blood from the injured blood vessel, we will look into the physiology of hemostasis. Now let me say this is one blood vessel that I have sketched here. Okay, so the inner side of the blood vessel is lined by what we call as endothelium. So these cells are representing the endothelial cells, and rest of the blood vessel wall is here, which primarily comprises of connective tissue. And when I say connective tissue, first thing that should come to our mind is the collagen. Apart from that, there will be a layer of smooth muscles. Okay, now let me say that for some reason there was a trauma and I have ended up injuring some area of the blood vessel. Okay, now because of this injury, there is a possibility that the RBCs that are there inside the blood vessel will start leaking out, right? So now the patient is bleeding. Now how the system can stop this blood loss from the injured blood vessel? That is what we will try to understand now. Just give me a second, guys. Okay, cool. Good evening Nuseba and good evening Garam Masala. Okay, so how? First, once I have caused the injury to these endothelial cells, I am exposing the substance which is just present behind the endothelial cells, which I have drawn in yellow colors. We call this factor as von Willebrand factor. We call this factor as von Willebrand factor. Okay, now to this von Willebrand factor, it was protected, it was not exposed to the circulating cells inside the blood vessel by this endothelial layer. But once I breached the endothelial layer, now I have exposed these von Willebrand factors, right? So these von Willebrand factors will now bind with the platelets. So in this circulating blood, there are platelets. So let me say these green colored cells are platelets. So these platelets will go and bind with these von Willebrand factors. That is one step, right? But even before that happens, there is another step that the blood vessel will take. You will have a layer of smooth muscles in the blood vessel which will contract, right? So they cause the constriction of the blood vessel. So if I constrict the blood vessel, obviously I can limit the loss of blood. That is step number one. Step number two is we try to create a plug of platelets at the site of injury. So for that, the plug of platelet to be formed, first platelet should come and attach to the site of injury, right? So this attachment is facilitated by the exposure of these von Willebrand factors. So platelets will come and bind to this von Willebrand factor. Now for platelets to bind to a substance, they need to have the receptors for that substance. So what is that receptor? Can anybody tell me which receptor I am addressing? Which receptor helps in binding the platelet with the von Willebrand factor? So let me say this is a platelet, right? On the surface of the platelet, you have this receptor called as glycoprotein 1B9. Glycoprotein 1B9. So this glycoprotein 1B9 will facilitate the binding of the platelet to von Willebrand factor, glycoprotein 1b9, or in simple words you can call it as glycoprotein 1b. So these platelets will now go and bind to this von Willebrand factor. That is the first step in creating the platelet plug. So once they bind, right, what we call this step as? This step is called as platelet adhesion. So now we have achieved adhesion of these platelets. So these platelets have gone and bound to the von Willebrand factor, and we achieved the first step, which is called as platelet adhesion, right? So the first step in formation of the platelet plug is platelet adhesion. And once the platelets adhere there, do you think just few platelets attaching to this injured site is enough? Probably no, right? Because inside the blood vessel there is a significant pressure created by the flow of blood, so they can easily push these platelets and still continue to bleed. So now what these platelets should do? These platelets should attract more platelets to come to this site so that they can create a proper plug, right? Now how do these platelets will attract more platelets to come to this site? They will send some chemical messengers. So this platelet, which is now bound to a von Willebrand factor, will send a chemical messenger. There are actually two chemical messengers. One of them is ADP, adenosine diphosphate, and the second one is thromboxane A2. Thromboxane A2. Okay, now we know, right? Why do we use aspirin as antiplatelet agent? Why aspirin is called as an antiplatelet agent? Because it inhibits the synthesis of thromboxane A2. So if I inhibit the synthesis of thromboxane A2, then in the prevention of blood loss, initial steps are not affected. The vasospasm or constriction of the blood vessel is not disturbed. Formation of a platelet adhesion, that is binding of von Willebrand factor and GP1B9, that is not disturbed. But once the adhesion happens, right, recruitment of further platelets to come to this site is disturbed because I am not sending the thromboxane A2 if I am giving someone aspirin. Okay. Now this thromboxane A2 and ADP act as platelet attractants. So they will attract more platelets to come to this site of injury, and we end up creating a platelet plug. Okay. Now this ADP particularly will require a receptor on the platelet so that it can bring that platelet to the site where the plug needs to be formed. So that receptor of the ADP that is present on the platelet is called as P2Y12. It is called as P2Y12. So can anybody give me an example of a drug which blocks this P2Y12 and thus again becomes an antiplatelet agent? P2Y12 blocker. P2Y12 blocker, right? You might have heard of a drug called as clopidogrel, ticagrelor. These are blockers of P2Y12. So if I give someone clopidogrel, what happens? First, adhesion unaffected, right? Secretion of the attractant chemomessengers unaffected. But this ADP will not be able to bind to the platelet, so it will not be able to bring the platelets to the site of injury. Initial adhesion will happen, but further recruitment of platelets for the formation of the platelet plug will not happen. Okay, but we forgot to address one important point. Okay, there was an injury, we created an adhesion. How did we achieve the adhesion? Because platelets had this glycoprotein 1b9 receptor, so this receptor could bind to von Willebrand factor. But now the new platelets that are coming, where will they bind? Because all the von Willebrand factors that were there, they are occupied by the initial platelets which were involved in the step of adhesion. The new platelets have to bind with the existing platelets which are already there as adhesion. So obviously they will also require a receptor. What is that receptor? That receptor is your glycoprotein, right? What is the receptor? Glycoprotein 2B3A. So we have one more receptor called as glycoprotein 2B3A. So this receptor will facilitate binding of another platelet to the existing platelet, interpositioned by a small molecule of fibrin. So a fibrin molecule and two platelets attach with the help of this glycoprotein 2b3a. So there are also drugs which can inhibit the glycoprotein 2b3a. So all these agents are going to act as antiplatelets because they are inhibiting the platelet plug formation, right? So we understood so far. Let me put it down in notes. So first thing is, when there is an injury to blood vessel and we start bleeding, blood vessel constricts. That is what we call as vasospasm. This is mediated by endothelin 1. This is mediated by endothelin 1. Okay. Now, once we have constricted the blood vessel, next is the platelet plug formation. The first step is adhesion, and the second step where initial adhesion has happened. In the adhesion, what has happened? The platelets are bound to von Willebrand factor. So there is a binding between von Willebrand factor and GP1B9. Second is to get more platelets to the site of injury. This step is what we call as platelet aggregation. So in the aggregation, first we have sent the messengers, that is adenosine diphosphate. Adenosine diphosphate has gone and bound to the receptor called as P2Y12 on the platelets and bring those platelets to the site of injury. Another messenger we have sent is thromboxane A2. Thromboxane A2 is also attracting the platelet to come to the site of injury. Once they come to the site of injury, they will bind to existing platelets with the help of glycoprotein 2b3a, right? And that completes the step of aggregation. Now, do you think this is sufficient enough for us to prevent the bleeding for a long time? The answer is no, right? Because there is so much of pressure inside the blood vessel. The pressure will definitely dislodge this platelet plug, and then again we will continue to bleed. So this is just an initial patch up. If your pipe is leaking, you can put some glue, that is initial patch up, right? This is not going to be a structure which can withhold for long. So now how can I reinforce this structure so that it becomes strong and then holds on and thus does not allow the further bleeding to happen? For that, we need to create a mesh of fibrin. That step is what we call as coagulation, right? So first step is vasospasm followed by a platelet plug formation. In platelet plug formation, we cause adhesion, recruitment, aggregation, and then we have to create a fibrin mesh formation. Okay. Now this fibrin exists in our blood in an inactive form called as fibrinogen, which needs to be converted to fibrin so that it creates a thread around it. So now what we do is we create a mesh of fibrin threads. Now this mesh of fibrin thread is a very strong structure. So now the bleeding is completely stopped. Okay. And this can hold on for a long period of time. So this gives sufficient time for the body to repair the injured endothelium and rest of the blood vessel. So once we repair, this clot will be cleared, right? So that is what we call as fibrin mesh formation or fibrin plug formation, which basically means we are converting inactive fibrinogen to fibrin. There are multiple steps involved in conversion of fibrinogen to fibrin, and this whole conversion of fibrinogen to fibrin is what we call as coagulation cascade. So this cascade will be activated by two different mechanisms. Okay, one is called as an extrinsic pathway, the other one is called as an intrinsic pathway. Extrinsic pathway or intrinsic pathway. What happens in extrinsic pathway? When there is injury to blood vessel, just like how we exposed von Willebrand factor, there are also factors called as tissue factor, which is present in the blood vessel wall and the surrounding tissues. So once the blood comes in contact with this tissue factor, it leads to activation of factor 7. It's a coagulation factor produced by liver. It gets activated. The activated factor 7 is what we call as factor 7a, which will further activate factor 10 to factor 10a. Okay, so this pathway where factor 7 plays the crucial role, we call it as extrinsic pathway. But if I put a needle into my blood vessel, take the blood, right, put it in a glass, will it clot or not? I put a needle into the blood vessel, removed it, put it in a glass. Will it clot or not? It will clot, right? But there is no tissue factor here because the needle has directly gone into the blood vessel and I've directly taken the blood from the blood vessel. So there is no tissue factor. So who is activating this clot formation then? Well, there is another cascade which gets activated with surface contact. We call it as intrinsic pathway. Whenever it comes in contact with any surface other than the endothelium, it gets activated. So in this cascade, we start with factor 12. 12 becomes activated to 12A. That activates 11. That activates 9. Right? And then with the help of factor 8 and the activated 9, we activate the factor 10 to factor 10A. Right? So this pathway is what we call as intrinsic pathway. So both the intrinsic and extrinsic pathways converge on activation of 10 to 10A, and this activated 10 converts prothrombin to thrombin, and thrombin then converts the fibrinogen to fibrin. This is how we create the fibrin threads. So this pathway where the two lines follow the same track, we call it as final common pathway. Clear? So once we have created a platelet plug, now we have to reinforce or make this structure more strong by creating fibrin threads around it. Fibrin threads are created by converting fibrinogen to fibrin, and to convert this fibrinogen to fibrin, we need to take these multiple steps, either an intrinsic pathway route or an extrinsic pathway route, which finally converge on the final common pathway, right? So once I create a fibrin mesh, the clot is strong. Now the bleeding is stopped. It gives sufficient time for the endothelium to heal or recreate new endothelial cells, right? Synthesize the connective tissue, and the site of bleeding is completely repaired. Once that is repaired, right, should this clot stay there or it should go? What do you think? Should this clot stay there or it should go? It should not stay, right? Because it is literally narrowing the blood vessel lumen. So this should be cleared once its job is done. Once the blood vessel is healed, this clot should be cleared. So how do we clear this clot? How can we clear this clot? How do we clear once we have created a fibrin? So basically we have to dissolve this fibrin. See, platelets and all would have been disintegrated by now, but the fibrin is the solid structure that needs to be dissolved. So how do we dissolve this fibrin? Okay, so in the body there is another important clot dissolving mechanism, right, which we call it as thrombolytic mechanism or fibrinolytic mechanism. So in the body there is something called as plasminogen. This plasminogen should be activated to plasmin, and this plasmin breaks down fibrin. So once we break down the fibrin, all the cells will be disintegrated and cleared. The clot will be cleared from that site. But who activates this plasminogen to plasmin? There is a substance called as tissue plasminogen activator or TPA. This will activate the plasminogen which is there in our body to plasmin, and this plasmin will break down the fibrin, and thus the clot will be cleared. And this is a mechanism that we use when we have to treat a condition where there is a clot in blood vessel. For example, if you have myocardial infarction because there is a clot in your coronary artery, or you have pulmonary thromboembolism, or you have a deep vein thrombosis, or you have a stroke where there is a clot in your middle cerebral artery or internal carotid artery, we give drugs called as thrombolytics or fibrinolytics. What do? They basically behave like tissue plasminogen activator. Either like we can use a drug which is nothing but genetically synthesized tissue plasminogen activator, we call it as recombinant tissue plasminogen activator or RTPA, or drugs behaving the same way as tissue plasminogen activator like alteplase, reticlase, tenecteplase. They all behave like TPA. They activate plasminogen to plasmin, and the plasmin will dissolve the clot. That is how we create these fibrinolytic agents. Okay, so this is the basic mechanism of preventing the bleed and eventually clearing the clot, right? So steps involved are first vasospasm, then formation of a platelet plug, then formation of a fibrin mesh, and then finally dissolving the fibrin plug once the healing is done. Okay, now if I have an abnormality of the blood vessel like you see in patients with vasculitis, I may not be able to cause initial vasoconstriction. I may bleed. If I have abnormal platelets, either platelets are low in number or they're functionally defective, means either there is no von Willebrand factor or there is some problem in glycoprotein GP1B9 or 2B3A, like right, if I have defects in platelets, either in terms of quality or quantity, then I will not be able to create the initial platelet adhesion or the aggregation. Thus, I will not be able to create a platelet plug. I may also have patients who have deficiency of the coagulation factors. Like, there is a disorder where coagulation factor 8 is deficient. What do we call it as? Hemophilia A, right? You also have patients who have coagulation factor 9 deficient, right? You also have patients who have coagulation factor 11 deficient. In all these circumstances, trivial trauma or without trauma, the patients have tendency to bleed, right? Now, once I get a patient who is complaining that he bleeds with minimal trauma or he bleeds without no trauma, my first step would be to clinically identify whether the problem is likely to be of the blood vessel or platelets, or whether it is a problem suggesting the problem of coagulation cascade, right? So how do we differentiate between a patient having the issue with platelet plug formation of blood vessel and patient having deficiency or abnormalities of the coagulation cascade? Labs will definitely help us identify, but clinically we can recognize. So what we will do is I will give you a small table which helps you to distinguish between a patient having platelet disorder and a patient having coagulation defect. Okay, so there are 6 parameters that we will look into. The first one is the presence of petechiae. Now, what do you mean by petechiae? So Tapas Samantha, see, whenever there is an injury to blood vessel and we start bleeding, for a quick fix, right, initially to quickly fix or patch up that site of bleeding, we create a platelet plug. Okay, but this platelet plug is not a strong structure. It will give way and then bleeding will continue after some time. So to make sure that the bleeding will not happen again from that site, we have to create a mesh of threads formed of fibrin, right? That's why we have 3 steps in hemostasis. The first one is constriction of the blood vessel, second one is platelet plug formation, and the third one is fibrin mesh formation, right? So when you say petechiae, it refers to bleeding into the skin. Okay, so when it is pinpoint, we call it as petechiae. Ecchymoses refers to large bleeds, right? So you have these 3 terms: petechiae, purpura, and ecchymoses. Pinpoint bleeds is what you call as petechiae, right? When they are relatively slightly larger but less than 1 centimeter in their maximum diameter, you can call them as purpura. But when they are more than 1 centimeter, you can call them as ecchymoses. Okay, so petechiae are very typical of disorders of the platelet and blood vessel. That is why when you say dengue, right, many dengue patients develop petechiae, and you even do a test called as tourniquet test. If the petechiae are not evident at the time of presentation, you try to induce it by tying a tourniquet and elevating the blood pressure, right? So petechiae is very typical of disorders of platelets. So if your platelets are low or they are dysfunctional, you can have petechiae. So they are typical of platelet disorders, right? They are rare if you have coagulation disorder. So you won't see a patient with hemophilia coming to you with pinpoint bleeding in the skin, right? But patients with dengue, they come with pinpoint bleeding in the skin. That is one point, right? Second, when you say ecchymosis, means relatively larger bleeding into the skin. Okay, so ecchymosis is very common in coagulation disorders, and not just common, but they're quite large. On the other hand, they are seen in platelet disorders, but they are relatively small. Okay, then third point, bleeding from superficial cuts. Superficial cuts in the sense like, okay, you're trying to shave and you develop a small cut. What do you think? A patient with platelet disorder will bleed continuously from the superficial cut, or it is a patient with coagulation disorder who will bleed continuously from a superficial cut? Right, see, once I get a superficial cut, what is the first step in preventing this bleed? It is the platelet plug formation, right? So if I don't form the platelet plug, then I will continue to bleed from that site, right? If I'm able to form a platelet plug, then this bleeding will stop quickly, right? So bleeding from superficial cuts is typical of platelet disorders and blood vessel disorders. It is rare when you have coagulation disorders. A patient with hemophilia won't come to you and say that, okay, I was shaving, sir, then I got a small clot, and since then it is continuously bleeding. On the other hand, patient who has deficient von Willebrand factor or abnormalities of glycoprotein GP1B9, right, or 2B3A or thrombocytopenia, they can come to us frequently and say, sir, I was shaving, I got a small cut, and since then it is continuously bleeding, it is not stopping. Okay. Then the fourth point, delayed bleeding, means you sustain trauma, immediately you don't notice bleeding, and later you start notice bleeding. What do you think that should point towards? Coagulation disorder or the platelet disorders? Study more. I am starting with the FMG series from 16. So we will be covering the high yield topics for the upcoming FMG exam. Delayed bleeding. Like, just to give you an example, that you were playing football, right? Ball came and hit some part of your body, right? Immediately you did not notice anything. But later there is a hematoma, right? Right, because the initial, as long as the platelets are fine, right, after the trauma, initial prevention of bleeding will happen, right? But after some time, the platelets cannot hold anymore. So if you have not created a fibrin mesh, then you will bleed. So delayed bleeding indicates that you have defects in coagulation cascade. So delayed bleeding is common when you have coagulation disorder. It is not typically seen when you have platelet disorder. Platelet disorder, immediately after the trauma you will start bleeding. Delayed bleeding indicates that you have a problem with the coagulation cascade. Okay. Then deep seated hematomas, means not bleeding into the skin, bleeding into deeper structures, is very common of the coagulation cascade disorders. It is rare in patients with platelet disorders. They mostly bleed superficially. Okay. And then there is one important finding, which is hemarthrosis. Hem means bleeding. Arthrosis means into the joint. So we are referring to bleeding into the joint, which is the most crippling and disabling symptom that patients with hemophilia experience. Because see, joints are structures which bear a lot of trauma day in and day out, right? When you're even walking on an uneven surface, your joints are bearing the trauma. But as long as your coagulation cascade is fine, your platelets are fine, you won't bleed into the joints. But if I have hemophilia, right, and if my joint sustains a minor trauma, some amount of bleed might happen, but that will be quickly patched up by the platelets as long as they are fine. But if I don't reinforce that platelet plug with the fibrin mesh, then I will start bleeding into the joint, right? So hemarthrosis is very common in patients with coagulation disorders. It is rare in patients with platelet disorder. So is it difficult for us to clinically differentiate between the defects of platelet plug formation and defects of the coagulation cascade? No, it is pretty easy, right? So those who present with tiny, small, superficial bleeds or bleeding soon after the trauma are most likely having the platelet disorders. Those who present with large superficial bleeds, that is ecchymotic patches, right, delayed bleeding, deep-seated bleeding or bleeding into the joint are mostly patients of coagulation disorders. So Samantha, hemarthrosis, right, as the name says, hem means we're referring to blood and arthrosis means we're referring to joints. So bleeding into the joints is what we call as hemarthrosis. So now looking at this image, what do you think? This patient, if I see him, should I start thinking of the platelet dysfunction or should I start thinking of the coagulation cascade abnormality? What should I think? Right, you can clearly see that there is swelling of the joints, probably because of the bleeding. So in that case, if patient has got bleeding into the joints, it means he must be having a coagulation cascade disorder, right? So it is not very difficult for us to clinically differentiate between platelet dysfunction and coagulation cascade disorders. But once we have made a clinical judgment, right, we also need to do some laboratory workup. So now let us look into what laboratory workup essentially we do. The important starting test whenever you have a patient with unusual bleeding tendencies, you do bleeding time, clotting time, prothrombin time and activated partial thromboplastin time or aPTT. Okay. So now you tell me, I have given you the normal values. So if I tell you that I have a patient who presented with some unusual bleeding tendency and I got these tests done and his bleeding time is high, should I suspect platelet disorders or should I suspect coagulation cascade disorder? Bleeding time is high. What should I think? Right. See, who is stopping after we create a trauma? right? Initially, who is stopping the blood loss? It is the platelet plug, right? So if I don't form the platelet plug, I will continue to bleed, right? So increased bleeding time indicates that you have platelet dysfunction, right? And then what is this clotting time? You take the blood, right? Put it in a test tube and see how much time it takes to form a clot, right? So basically you are assessing the extrinsic pathway, surface contact triggering the coagulation, right? So if you have elevated clotting time, what does that indicate? It probably indicates that you have coagulation disorder. So if the bleeding time is increased, it means you have the platelet disorders. Platelet disorders. And if the clotting time is increased, it indicates coagulation disorders. Okay. Now in coagulation disorders also, I want to understand whether the pathology is affecting the extrinsic pathway or whether the pathology is affecting the intrinsic pathway, right? Is that possible? Yes, that is possible. So please remember, it is the factor 7 which is most important factor involved in the extrinsic pathway, and in the intrinsic pathway, multiple factors, right? Okay. So in factor 7, the best test that assesses the integrity of this pathway or this cascade is the prothrombin time. Prothrombin time. So if the prothrombin time is elevated, that means you have a defect in the extrinsic pathway, right? Can you give me an example where this prothrombin time can be elevated? Atul Singh, can you repost the question? I think I've missed it somewhere. Can you give me one example where the prothrombin time will be elevated? Okay, just one example. You might have seen a lot of patients with chronic liver disease, right? Alcoholic cirrhosis. They will have elevated prothrombin time. Why do they have elevated prothrombin time? Because in them, the factor 7 will be low. Not just the factor 7, right? There are various other factors which will be low. Why those factors will be low? Because those factors require vitamin K for the synthesis by the liver. Okay, Atul Singh, in the coagulation disorders, when you bleed, right, you bleed profusely. So you will not bleed small quantities, you will bleed large quantities. That is why we end up getting ecchymoses rather than small bleeds. But when you have platelet defects, right, the bleeds will be smaller. They will not create large aggregates, right? Larger bleeds are unlikely when you have platelet disorder. That's why I repeatedly tell my students who are studying dengue, right? Most of the times, like relatives, students, everyone keep calling me saying, sir, platelet is 30,000, platelet count is 40,000. I'm so much worried, right? Most of the patients of dengue don't die because of the low platelet count. The guidelines recommend that under, like, as long as platelet count is more than 20,000, we should not transfuse. But many doctors end up transfusing platelets just because of the peer pressure or pressure from the patient's family side, which is irrational and uncalled for. Because when platelets go low, right, catastrophic bleeding is less likely. Until and unless there is a major trauma or a surgery, as long as your platelet count is 20,000 plus, you will not bleed massively. So bleeding will be tiny, like from the gum. That is what we call as superficial bleeds, right? You may bleed while brushing. You may develop those tiny petechial spots. You will not get large bleeds. So ecchymoses are relatively large bleeds. Okay. If a patient of dengue dies, it's most likely because of what we call as dengue shock syndrome. Okay. Now, why we have elevated prothrombin time in chronic liver disease patients? Because liver is the site of synthesis of various coagulation factors, particularly those which are vitamin K dependent. What are the vitamin K dependent coagulation factors? 2, 7, 9, 10, right? These are vitamin K dependent coagulation factors. That is why one of the drug that we use when we want to stop the blood clot from forming, what we call as anticoagulants, is warfarin. What warfarin do? Warfarin is a vitamin K antagonist. So it blocks the vitamin K. Warfarin blocks the vitamin K. So if it blocks the vitamin K, then factor 2, 7, 9, 10 synthesis will come down. So once its synthesis comes down, right, your extrinsic pathway goes dysfunctional. So you will not be able to create a clot. That is how warfarin becomes an anticoagulant. And whether we are giving the right dose of warfarin or not, how do we assess? By looking at the prothrombin time, right? because prothrombin time will be affected whenever the factor 7 levels will be decreased. Cool. So that was Samantha absolutely right. See, when platelet count is 1.5 lakh plus, absolutely there is no need for transfusion. Even see, there is something called as National Vector-Borne Disease Control Program run by Government of India, which guidelines recommend that when the platelet count, for whatever reason, maybe dengue, immune thrombocytopenic purpura or various other conditions, as long as it is more than 20,000, there is generally no need for transfusion. When it is between 10 to 20,000, if there is a tendency to bleed, that is when they are bleeding from the gum or they have petechiae, then we should transfuse. Less than 10,000, we can transfuse prophylactically, means to prevent bleeding from happening. 10 to 20,000, if there is evidence or tendency to bleed. More than 20,000, generally it is not required until and unless the patient is going for a surgical intervention, right, or an anticipated trauma. Okay, so prothrombin time helps us to assess the integrity of extrinsic pathway. If the prothrombin time is elevated, that means your extrinsic pathway is defective, and it is the activated partial thromboplastin time or the aPTT. aPTT is the one which assesses the integrity of the intrinsic pathway. So if aPTT is elevated, then I have defect in the intrinsic pathway. So one of the drugs that we are all familiar with is heparin. Heparin primarily interferes with the intrinsic pathway. That is why when we give heparin to someone, we see that aPTT goes up, and whether we are giving the right dose of heparin or not, we assess by looking at the patient's aPTT. Okay, so now you should tell me, if I have a patient with von Willebrand disease, means he is not able to produce sufficient quantity of von Willebrand factor, should I count it as a coagulation disorder or should I count it as a platelet disorder? For what we need this von Willebrand factor? For initial platelet adhesion, right? So if I have deficiency of von Willebrand factor, probably I will not be able to create initial adhesion, right? Good, Atul Singh, absolutely right. So in that case, what all parameters I will find abnormal in this patient's lab reports? What will happen to the bleeding time in a patient with von Willebrand disorder? Bleeding time in a patient with von Willebrand disease. Yes, that will be increased, right? Okay. Then when I look into the clotting time, right? What do I find in patients with von Willebrand disease, the clotting time? Clotting time probably will not be greatly increased. It will be either normal or marginally increased. Okay. On the other hand, if I have a patient, let me say I have hemophilia A or hemophilia B. Okay. So in that case, what will happen to the bleeding time for a patient with hemophilia? Bleeding time. That will be normal, right? Because their platelets are fine. What will be elevated? Their clotting time. Their clotting time will be elevated. Right? Now, in a patient with hemophilia, if I do prothrombin time and aPTT, what will be the result? Nussebar, right? So clotting time will be increased because the patient is having a coagulation disorder. Bleeding time will be normal, clotting time will be increased in a patient with hemophilia. But when I further look into the prothrombin time and aPTT, what do I find? In a patient with hemophilia. Okay, so in patient with hemophilia A, right? Does it have anything to do with factor 7? Absolutely no, right? So as long as factor 7 is fine, prothrombin time will be fine. But what about the aPTT? What about the aPTT? aPTT will be increased, right? aPTT will be increased. Okay, now if I have a defect in this final common pathway, right, I have an abnormality of thrombin, let me say, right, or if I have inherited a mutation in the fibrin itself, I have defective fibrinogen. In such cases, what will happen? Both prothrombin and aPTT will be elevated, right? So in intrinsic pathway defects, aPTT will be elevated, extrinsic pathway defect, PT will be elevated, common pathway defect, both will be elevated. Platelet disorders, it is the bleeding time that will be elevated. Okay, so Tapa, when we cause injury to the endothelium, right, and we start bleeding, to stop the bleeding, the first step, as we learned, is cause the blood vessel constriction. But that's not a very great step, right? We have to patch the site of injury by creating a platelet adhesion. How do the platelets will go and adhere to the site of injury? Because there is exposed von Willebrand factor, and platelets have a receptor which recognize this von Willebrand factor. What is that receptor? That is glycoprotein GP1B9. So this will go and bind to the von Willebrand factor, and that is how we create this initial platelet adhesion. So if von Willebrand factor is not there, then will I be able to create the adhesion? If I'm not able to create the adhesion, will I be able to create the aggregation? No, right? So I will continue to bleed. Soon after the trauma, I will continue to bleed. Yeah, so if you have defective factor, see factor 10 to fibrin, right, is all what we call as common final pathway. So if you have a defect of the final common pathway, prothrombin and aPTT both will be elevated. Okay. So if the PT is increased, there is one more point to learn here, because prothrombin time is very subjective and the values vary from lab to lab. To kind of compare the values derived from different labs, we come across another term called as international normalized ratio, or INR, which normally is approximately around 1. So when it is more than 1, that means the prothrombin time is increased. When it is less than 1, that means the prothrombin time is, like when it is 1, the prothrombin time is normal. Okay, so increased prothrombin time indicates, increased PT indicates disorders of extrinsic pathway. Example we can give you is use of vitamin K antagonists like warfarin. Okay, and aPTT will be increased intrinsic pathway defects. Examples we are quoting here is hemophilias and heparin. Okay, so that's a basic approach. So what we do is, whenever someone presents with unusual bleeding tendency, clinically we will try to distinguish whether the problem is in the platelets or whether it is the coagulation cascade. How do I understand? When there are bleeds which are pinpoint, right, that is petechiae, bleeding from the superficial cuts immediately after the trauma, that is all pointing towards the platelet dysfunction. And if there are larger bleeds into the skin, what we call as the ecchymoses, right, or there is delayed bleeding after the trauma, not immediately after the trauma, but there is some delay and then bleeding happening, bleeding in deeper structures, right, inside the muscle, inside the organs, or inside the joints, that is all pointing towards the defect of the coagulation cascade. So from the clinical grounds, we can come to some initial conclusion, and then we will go to the lab test. In the lab test, first thing I will see is the BT and CT. If BT is increased, it is pointing towards the platelet dysfunction. If CT is increased, it is pointing towards the coagulation cascade dysfunction. And if it is the coagulation cascade dysfunction, I will further try to understand whether it is the intrinsic pathway or extrinsic pathway that is being affected by looking at PT and aPTT, right? PT elevated alone indicates that you have a defective extrinsic pathway. aPTT elevated indicates that you have defective intrinsic pathway, right? So once we are done with that, we will have a fair idea whether we are dealing with the platelet dysfunction or whether we are dealing with the coagulation cascade dysfunction, and more precisely, if it is coagulation cascade dysfunction, whether it is a dysfunction of intrinsic or extrinsic or final common pathway. Based on that, we can channelize our energy for further test. For example, if someone has presented with deep-seated bleeds, hemarthrosis, and I look at the BT-CT, CT is elevated, all of this is pointing towards the coagulation cascade defect. I get PT and aPTT done, and I get to know that aPTT is elevated. So now I'm thinking of a intrinsic pathway defect, most likely hemophilias or drugs like heparin, right? So all I need to do is ask him whether he is on any drugs. From the drug history, if he says that I'm taking some low molecular heparin, then that explains it. And if he says that he is not on any drugs, then I would start thinking of hemophilia. Now to understand precisely which type of hemophilia it is, hemophilia A, B or C, I need further test to assess the coagulation factor levels. Then I have to assess the factors 8, factor 9 and factor 11 levels. So heparin blocks at multiple levels. Heparin blocks the multiple levels. Okay, so I will just give you a summary of the platelet disorders that you need to know and the summary of the coagulation disorders. So platelet disorders, we classify them as qualitative and quantitative. Now what do I mean by qualitative? When I say qualitative, it means the quality of platelets is not right. Number wise it is fine, right? The platelet count is normal, but they're not able to do their job, right? On the other hand, when you say quantitative, that means the platelet functionally they are fine, but their number is less, right? So qualitative, there can be defects in the process of adhesion, or there can be defect in the process of aggregation, right? Adhesion defect, a classical example is von Willebrand disease, where there is deficiency of von Willebrand factor. Deficiency of von Willebrand factor. Okay, and then you have a disorder called as Bernard-Soulier syndrome. Can anybody tell me what is the deficit or what is the abnormality in Bernard-Soulier syndrome? So these patients have defective glycoprotein 1b9. So for what purpose this is required? Glycoprotein 1b9, it is required for binding of von Willebrand factor and the platelet. This is acting as the receptor, right? Okay, then an aggregation defect is the Glanzmann thrombosthenia, right? Can anybody tell me what is the defect here? What is the abnormality here? These patients have defective glycoprotein 2b3a. So if I have defective 2b3a, then I will be able to achieve the initial adhesion, right? For adhesion, I need a von Willebrand factor and GP1b9. But for aggregation, I need to send ADP, thrombexin A2. ADP will recruit more platelets with the help of P2 vital receptors, right? And whatever platelets that are coming to the site, they will bind to the existing adhesed platelets with the help of GP2b3a. So if I have defective GP2b3a, I will not be able to achieve this aggregation. The end result is platelet plug will not be formed. This condition is what we call as Glanzmann's thrombosthenia. So Bernard-Soulier syndrome is another platelet disorder where patients will present with same things that we discussed now. The superficial bleeds, petechiae, right? Elevated bleeding time. All of that is happening because these people have inherited abnormal glycoprotein GP1b9. Okay. Then quantitative means when the platelet count is decreased, right? They are not able to produce the normal number of platelets required. It can be inherited, not important for us because they are very, very rare. Acquired, a long list of causes, right? So I will just mention few causes where you can acquire a decreased number of platelets, what we call as thrombocytopenia, right? When we say quantitative means decreased platelet count, right? When you say qualitative, that means defective platelets. Their function is not proper. They are not able to do their job. Defective platelets. So here there is decreased platelet count, right? Examples. Sutapa Samantha, aggregation defect means, as we learned, right, when we have to stop bleeding from a blood vessel, we are creating a platelet plug. The platelet plug formation itself involves multiple steps. The first step is that few platelets will go and attach to the site of injury to the von Willebrand factor. That is the adhesion step, right? They are attaching. But once they attach, more platelets should come and attach to that existing platelets. So this more platelets coming and attaching to the existing platelets is what we call as aggregation. Basically, just to give you an example, right? Okay, if you come out of your room in the hostel and you see a snake, okay, now you're scared. What you will do? You will close your door, but you will also tell everybody else to come and see the snake. So everybody else coming to the site is the aggregation, right? You going to the site where the snake was found is the initial adhesion. Everybody else, you tell everyone, right? You call, message and say that there is a snake here, snake here. So everybody else will come to the site. That is the aggregation, right? Okay. So acquired examples, your viral fevers. Viral fevers, like for example, dengue, and there is a long list of viral disorders called as viral hemorrhagic fevers. Dengue is also one of them. Okay. Then other than that, drugs. Can anybody give me examples of drugs which are known to cause decrease in platelet count or thrombocytopenia? Decrease in platelet counts or thrombocytopenia. How many of you have heard about this heparin induced thrombocytopenia or HIT? So heparin not only blocks the coagulation cascade. In some individuals, it can trigger an autoimmune process where body produces antibodies against the platelets, right? So heparin can cause thrombocytopenia. Yes, steroids can cause thrombocytopenia. Okay, you might have heard about an antibiotic called as linezolid, which can cause thrombocytopenia. VHF refers to viral hemorrhagic fevers. So these are the fevers caused by viruses where the patient have tendency to bleed. Why they have the tendency to bleed? Because the platelet number is gone down. A classical example is dengue. There's a long list of examples that you will study in microbiology, right? So drugs. Then there is another condition called as thrombotic microangiopathies. Thrombotic microangiopathies. What does that refer to? Also abbreviated as TMAs. Means these are the conditions where clots first form in the blood vessel because the whole coagulation cascade and the platelet plug formation is activated. But once too many clots form, what happens? All the platelets are being used up in forming those clots. So what will happen to the number of circulating platelets? It will come down because all the platelets are being utilized in formation of multiple clots in the body. A classical example for this I can quote is there is something called as disseminated intravascular coagulation or DIC. Recent times when we lost so many patients to COVID, at least a reasonable number of them died because of this condition called as disseminated intravascular coagulation. No need to fret about it. As you start getting into the clinical postings, right, you will encounter plenty of these patients with DIC in the ICUs. Okay. Then you might have heard about hemolytic uremic syndrome and thrombocytopenic purpura or TTP. DIC refers to disseminated intravascular coagulation. A classical example for DIC is after you develop sepsis, right? Many patients in sepsis die because of disseminated intravascular coagulation. I'll tell you what happens in DIC. So in DIC, right, I'm giving you an example as a cause for DIC, which is sepsis. So in sepsis, what happens? There is increased production of interleukin 6 because of the infection. So this interleukin 6 will go and damage your endothelium. And as we know, once we cause the damage to endothelium, what will happen? Von Willebrand factors are exposed. The exposed von Willebrand factor will cause the platelet adhesion. Eventually, there will be platelet aggregation and then activation of the coagulation cascade, and I will create the fibrin meshwork. So multiple sites in the body where there is endothelial injury, I am creating the clots everywhere. But in creating such clots, what am I using? I am using the platelets and fibrin, right? So in that case, when you check the fibrin levels in my blood and you check the platelet count in my blood, what will happen? The platelet count will be low because all those platelets are being used up in creating multiple clots everywhere, right? The fibrin is being used up, so my fibrinogen level will be down, right? And once this fibrin is used up, this will be broken down by the tissue plasminogen activator, that is the plasmin. So fibrin degradation product that will be elevated in patients with disseminated intravascular coagulation. Okay, so that is a brief about platelet disorders. Just a quick take on the coagulation disorders, right? Coagulation disorders means the defect is in the coagulation cascade. So this also can be either hereditary or acquired, right? So when we talk about acquired, it is most likely caused by drugs, as we just learned, like warfarin, right? Then dabigatran. These are all anticoagulants. We use it for therapeutic purpose, but if you overdose, they will cause the tendency to bleed. Okay. See, inherited causes, there is a long list. Actually, we don't need to really remember them, but if you want, I will give you the list. Okay, so this is a list of all the inherited disorders of coagulation, the platelet dysfunction. That includes plenty of autosomal dominant and autosomal recessive and X-linked recessive. They're extremely rare. Rare in the sense that probably none of us will encounter these patients in our clinical practice of 20-30 years. And that's why you don't see many questions being asked about them, right? Most of you may not even get these names in your standard pathology textbooks. So that's why I didn't get into it. But if you want, you can make a note of these disorders like autosomal dominant are May-Haggin syndrome, Sebastian, Epstein, Fechner's, autosomal recessive, few important ones I've already discussed, right? Okay. Now coming back to what I was talking to you. See, once we create a fibrin mesh, we just learned that that clot will be cleared by the plasmin, right? So plasmin will grow and break those fibrin. So once I break the fibrin, the end products of the broken fibrin is what we call as fibrin degradation product. So if there are too many clots formed and they are being broken down, what will happen to the fibrin degradation product? That will be elevated, right? Okay. So for acquired drugs is one cause, and another example I can give you is chronic liver disease or cirrhosis, because liver is the site of synthesis of most of your coagulation factors, right? And then another condition is vitamin K deficiency, because vitamin K is required for the synthesis of factors. What are the factors? 2, 7, 9, 10. They are dependent on vitamin K. Inherited coagulation cascade disorders are hemophilia A, which is due to deficiency of factor 8, right? And then deficiency of factor 9 leads to hemophilia B, and deficiency of factor 11 leads to hemophilia C, right? So that's it about the disorders or the patients presenting with bleeding tendencies. I will leave some MCQs for you to solve. Basically, the MCQs on this topic test whether clinically you can distinguish a platelet disorder versus a coagulation cascade disorder. Second level of question is whether you can distinguish a platelet disorder and a coagulation cascade disorder based on the laboratory data, that is BTCT, PT, aPTT, and whether you can distinguish the intrinsic factor, the intrinsic or the extrinsic pathway disorders based on the interpretation of PT, aPTT. CLD refers to chronic liver disease, basically liver failure or cirrhosis of liver. Garamasala, I didn't understand what do you mean by M bar M. Okay, the next session will be on Monday, and I'll let you know the topic soon. Okay, so I will leave you some MCQs, please solve them, and what we will do is from okay, so Atul, there are multiple reasons. Okay, so to give you an example of dengue, right? Dengue does two things. One, dengue affects the bone marrow, because in dengue there is increased production of inflammatory cytokines which cause the marrow suppression, and that is why the number of platelets produced by the bone marrow comes down. But that's only one aspect of it. The second aspect is dengue virus is directly toxic or pathic to the platelets, so they can cause destruction of platelets as well as decreased production. Both are involved. So for different viruses, there are different mechanisms. Some viruses only cause decreased production, some viruses increase the destruction, some do both, multiple mechanisms. But plenty of viruses have a tendency to cause thrombocytopenia. So as a physician, I wouldn't be surprised if someone comes to me and says, sir, I've got 3-4 days of fever and this is my CBC report and I see a platelet count of 1,20,000, 1,30,000. It's not uncommon at all. It's so common. Once you become an intern, you will see plenty of these patients. And nowadays that we don't even bother so much to differentiate whether it is dengue or other viral hemorrhagic fevers, because the management is pretty safe. Whether it is dengue or other viral hemorrhagic fevers, there are only two issues. One is there is leaking of fluid from the blood vessels into the third space, means subcutaneous plane, right, pleural cavity, peritoneal cavity. That's why patients with dengue often develop pleural effusion, ascites, right? That is a major concern, because once you leak fluid from the blood vessel, the amount of fluid inside the blood vessel comes down. So you head towards shock because your BP will drop and then patients can die. The second thing is that platelets can drop down. So generally when we have these viral hemorrhagic fevers, what we do is primary focus is on assessing whether the platelet is leaking fluid into the spaces. For that we look at the patient's hematocrit, right? If the hematocrit is increasing, what does that point towards? That means the amount of fluid in the blood is coming down. That is why the blood is getting concentrated. That's why hematocrit is increasing. That's what we call as packed cell volume. That is increasing because the fluid in the blood vessel is coming down. So any dengue or any patient with viral fever, if you see that their hematocrit is increasing, that's a danger sign. Platelet counts, yes, most of the viral fevers, as we know, including dengue, platelet count will drop, but it becomes life-threatening in only few individuals, right? Okay, see, management obviously depends on the cause, right? So if it is the platelet dysfunction, management is difficult, but if there are a treatable cause for a platelet disorder, we can treat, right? For example, if some drugs are responsible for the thrombocytopenia, for example, heparin-induced thrombocytopenia, we can promptly withdraw the heparin, right? But otherwise, most of the inherited platelet disorders are difficult to treat. But the inherited coagulation cascade disorders are relatively easy to treat. In the sense, I wouldn't say easy because that is an injustice to the patients who are suffering through them, but we have found the ways to handle them, right? For example, if I have hemophilia, we can replace the factors, right? We have recombinant factor 8, factor 9, factor 11, those can be replaced. Apart from that, we can also consider giving them fresh frozen plasma or the factor concentrates. When patients donate blood, we can only get the plasma from them, or we can extract the coagulation factors and then transfuse them to the needy patients who are having the deficiencies, right? So we will go through the management of all the diseases when we take up the second part of the Harrison. So for now, we will concentrate more on the clinical approach, reaching to a conclusive diagnosis on clinical grounds and lab methods. Oh, that's it for today, guys. I will see you on Monday. We will continue with this Read Harrison series. See you soon. Good night. And please don't miss out on solving the MCQs. Bye, guys. Bye-bye.